Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐢𝐚𝐴. I am the General Medicine Educator. So in this session, I will be doing a quick revision of the entire neurology topics. So the topics which I will be doing the quick revision is the epilepsy, meningitis, cerebrovascular accidents. So you take the first topic, that is the epilepsy. So in this, you need to know the two important terminologies. One is the seizures, right? And then the epilepsy. Now, apart from this seizures and epilepsy, we have one more terminology, that is the convulsions. Now, what is the difference between these three, that is seizures, epilepsy, and as well as convulsions? So, if you take this terminology, that is seizures, it is a single episode of the involuntary movement. And this single episode of the involuntary movement, it is the one which occurs sudden in onset. Right, it is the one which occurs sudden in onset, and it will be transitory, right? So it will stay only for a very short period of time, or that event or episode will be there only for short period of time. And this particular seizure, which is a sudden in onset, this is basically due to abnormal discharge of the neuronal cells. And this abnormal discharge of the neuronal cells, that is associated with abnormal motor activity. These patients will have the abnormal sensory events, and these individuals will also have the abnormal behavioral changes, right? So this is what is your seizure, which is a single episode, which is sudden in onset, which is transitory, and that is mainly because of the brain dysfunction resulting from the abnormal discharge of the neuronal cells. Now, you take this terminology, that is epilepsy. Now, one more point, this particular seizure where we are discussing that it is due to abnormal discharge of the neuronal cells. Now, what will be that abnormal discharge from the neuronal cells is there will be abnormal release of the excitatory neurotransmitters. Now, what are these excitatory neurotransmitters that will be released? The excitatory neurotransmitters that will be released are, number one, the aspartate, right, and number two, the glutamate, right, aspartate and as well as the glutamate. So these are released in excess quantity, and that will be associated with the involuntary movements, right, abnormal motor, sensory and behavioral changes, right? Then what is epilepsy? So if you take this epilepsy, if the number of episodes of seizures, if they are like more than or equal to 2 episodes of seizures, then we call it as the epilepsy. Then what exactly is your convulsion? The convulsion mean, like in a seizure, you have a motor component, sensory component, and as well as the behavioral component. Convulsion mean the motor manifestation of the seizure. That is what is called as the convulsion, right? And so motor manifestation of the epilepsy is nothing but the convulsion. Now this motor manifestation, how is that it can be controlled, or how is that it can be treated? So it can be treated with the help of these particular drugs, that is number one, lorazepam, right, and another important drug, that is the diazepam. So the motor component of the epilepsy is treated with lorazepam or the diazepam, right? Then you take the electrical activity. So there is like abnormal discharge, right, which is nothing but the electrical activity. So how is that the electrical activity can be controlled? The electrical activity of the seizure or the epilepsy, that can be controlled by the anti-epileptic drugs, that is lamotrigine, right? Or we have another important molecule, that is levetiracetam. So the electrical activity is controlled by lamotrigine or levetiracetam. Now, if you take the classification of the seizures, so the seizures, they are classified into the two main types. Number one, the focal epilepsy, and the other one is, right, and the other one is the generalized seizures or generalized epilepsy. Now this focal epilepsy, right, previously it was called as the partial epilepsy, and this partial epilepsy, which was again classified as the simple partial epilepsy and as well as the complex partial epilepsy. So simple partial epilepsy is that where there is no loss of consciousness, right? Whereas in case of complex partial epilepsy, there is loss of the consciousness. Okay. Then coming to the generalized seizures or the generalized epilepsy. So if you take the classification of the generalized seizures, that includes number 1, generalized tonic-clonic seizures, number 2, the absence seizures. So this we again classify it into the typical absence and atypical absence, right? And third one is atonic seizures, right? And the fourth one is the myoclonic epilepsy, right? The fourth one is the myoclonic epilepsy. So this is how we classify the generalized epilepsy, right? Now we'll try to take up the discussion of, and we have one more important form of seizures called psychogenic seizures. Psychogenic seizures, they are non-epileptic seizures. They are non-epileptic seizures. These psychogenic seizures, right? These psychogenic seizures, they are also called as the pseudo seizures, right? They are also called as the pseudo seizures, right? And these psychogenic seizures or pseudo seizures, they are not the result of the abnormal cortical discharge, right? And these psychogenic seizures, they are often associated with major stress. They are associated with emotional trauma, right? Which one? The psychogenic seizures or non-epileptic seizures or the pseudo seizures, right? Now, whereas your focal and as well as generalized, they are nothing but your neurogenic seizures. They are nothing but your neurogenic seizures, all right? Now, let me take up the discussion of the first, that is the GTCS. Okay, before going on to the GTCS, we have one more important form of the epilepsy, which is called as the status epilepticus, right? Or status epilepsy. Now, what exactly is the definition of the status epilepsy is that, right? Here, these individuals, they will be having the continuous episodes of seizures, right? There will be continuous episodes of seizures. And between the episodes of seizures, the individual will be in a state of loss of consciousness, right? The consciousness is not regained. Okay, between the episodes of the seizures, the individual will be in a state of loss of consciousness, all right? Now, the point here you need to understand is, the definition is either the single episode, it should be lasting for 5 minutes, right? Or this entire episodes, they should be lasting for nearly around 30 minutes. They should be lasting for nearly around 30 minutes. That is what is called as the status epilepticus, right? And what exactly is the drug of choice for status epilepticus? The drug of choice for the status epilepticus, it is lorazepam, right? So lorazepam, it is considered as the drug of choice, okay? And the dosage of this lorazepam is 0.1 to 0.4 milligrams per kg body weight. So that will be the dosage of the lorazepam, right? Now, this particular lorazepam, you give one shot. If the status epilepsy is still continuing, then you need to give one more shot of the lorazepam. Now, in spite of 2 doses of lorazepam, if the individual is still having the continuing status epilepticus, then in such case, you need to start with the other alternative anti-epileptic drugs. That includes valproate, phenobarbital, phenytoin, that is fosphenytoin. Now, in spite of giving all these drugs, if the patient is still having status epilepticus, then, or if the seizure episodes are continuing, then you need to knock out the patient with an anesthetic agent, right? So where we give the pentobarbital or propofol we give, and then we knock out the patient, okay? So that is about your status epilepticus, right? Now if you take the types of seizures according to the age of the individual, what is the most common type of seizures that you will observe in the neonates? The most common type of seizures that you will observe in the neonates, that includes the subtle seizures, right? That includes the subtle seizures, okay? Whereas if you take the most common type of seizures within the children, right? The most common type of seizures in the children, the most common type of seizures in the children, that includes the febrile seizures. And another name for these febrile seizures, they are also called as, right, they are also called as benign Rolandic epilepsy. Right, this is also called benign Rolandic epilepsy. All right. Now, this benign Rolandic epilepsy, why is it called as benign Rolandic epilepsy? Because it begins in the Rolandic fissure. Okay, so the febrile seizures, they begin in the Rolandic fissure, which corresponds to area number 4. That is the reason why it is called benign Rolandic epilepsy, right? And what is the most common cause of seizures? Right, most common cause of seizures in individual of age group less than 18 years. The most common type of seizures or most common cause of seizures of individual of age group 18 years, that will be the GTCS. And the cause of the GTCS at this age group around 18, that is mainly due to drug abuse. That is mainly due to drug abuse. Okay. Then what is the most common cause of the seizures in adults? In adults also it is the same, that is GTCS, generalized tonic-clonic seizures. But the cause of the generalized tonic-clonic seizures in adults, that will be usually the cerebrovascular accidents. Cerebrovascular accidents. Okay, right. Then let us discuss few important points about the GTCS, generalized tonic-clonic seizures. I said you this is the most common epilepsy in adults. So you have two important things here. So one is the tonic and as well as the clonic movement, right? So tonic movement and then clonic movement. So they have a violent jerky movements, right? So they have a violent jerky movements, and not only that, there will be also a froth which is coming from the corners of the mouth. And you will also notice that there is uprolling of the eyeballs. You will also notice that there is uprolling of the eyeballs. And what about the tongue bite? The tongue bite, right, it may or may not be present. Okay, and there will be both urinary and as well as the stool incontinence, right, urinary and stool incontinence. And what is the duration of one episode of the GTCS? The duration of one episode of the GTCS, that is around 30 to 60 seconds. That will be the duration of one episode of the GTCS, right? Now, how do you treat these patients with the GTCS? And very important point is the tongue, it may fall back and that will obstruct the airway during the episode of the generalized tonic-clonic seizures. And there is sympathomimetic activity. There is increased sympathetic activity during the episode of the seizures. So the heart rate increases, the blood pressure of the individual increases, and even if you observe the pupils, they are dilated in patients with the generalized tonic-clonic seizures, right? Then how is that you treat the patient? So if the individual is having GTCS in front of you, right? So immediately you need to secure the IV line, right? And you need to give IV diazepam or IV lorazepam should be given, right? IV diazepam or the IV lorazepam should be given mainly to control the convulsions, right? Then followed by that, you take the postictal period. So in the that means immediately after the episode of seizures, the individual will be in a state of the confusion. So there will be postictal confusion, right? And how is that you will be able to diagnose this postictal period? So you will be able to diagnose this postictal period, right, by the individual not being responsive. The individual will be unresponsive to the commands, right? And the Babinski sign will be positive. The Babinski sign will be positive, and the corneal reflex will be absent in the postictal period. Then how is that you will work out these patients is you need to do imaging, CT or MRI of the brain in order to look for the presence of the CNS lesions, right? And then you also need to do the EEG, right? And then you also need to check for the presence of any electrolyte abnormalities, right? And you also need to check for the blood glucose levels in order to see whether the individual is having either any hyperglycemia or hypoglycemia. Now, in GTCS, what exactly is the drug of choice? In GTCS, the drug of choice will be the valproic acid. Now, apart from the valproic acid, the other alternative drugs that can be given in case of the GTCS is you can give levetiracetam, you can give lamotrigine also. Then, if at all, if there is mortality in patients with the GTCS, what is the cause of death? The cause of death is the aspiration pneumonitis, because during the episode of seizure, the individual will be in a state of loss of consciousness, or the individual will be in a state of the altered sensorium, right? Aspiration pneumonitis. Then next is the metabolic acidosis, right? Because the entire muscles, all the muscles in the body, they undergo the severe contraction, so the metabolic activity increases, so the oxygen is not available for the tissues, so these patients will go into a state of anaerobic metabolism there, where there is excessive lactic acid production, and that will result in metabolic acidosis. Then followed by that, these patients will also have the hyperthermia, right? These patients will also have hyperthermia. I mean, that is also the cause of death. So this is in short about the GTCS. Then the another important form of the generalized seizures will be the absence seizures. See, the absence seizures, the another name for this is also called as the petit mal epilepsy, and this is commonly observed in children of age group 2 to, right, commonly observed in children of 2 to 10 years. Now, if you take one episode of the absence seizures, the one episode of the absence seizures, it will last for only few seconds, right? So this will last for only few seconds, right? And the individual immediately will return back to the normal consciousness, okay? And these patients with absence seizures, there will be no post-ictal confusion, right? There will be no post-ictal confusion, okay? And not only that, there is also no loss of the postural control, right? There is no loss of the postural control, okay? And in case of the absence seizures, the number of episodes, if you observe, there are multiple number of episodes that can occur in a day. Multiple number of episodes. There can be even 100 episodes per day, okay? But the patient will not be aware of the episode, because the individual, how the episode will be, the episode will be in a form of a staring look for few seconds, right? Blinking may or may not be there, okay? So he'll be having a staring look, and he briefly stops talking also, and he don't respond during that period of time, and immediately he will regain the consciousness. And even after the regaining the consciousness, there is no post-ictal confusion, so the patient is not aware that he had an episode of the seizure, right? Now, how is that you can stimulate the, how you can provocate the development of the absence seizure is, like, you ask the child to do this hyperventilation, right? Hyperventilation. Or you just give a photic stimulation to the eye. So the hyperventilation or photic stimulation will trigger the development of this absence seizures. And these absence seizures, I said you, they start at around 2 to 10 years of age, right? And by the time the individual reaches around 20 years, the absence seizures, right, they completely stop. The absence seizures will stop. And how is that you will diagnose these absence seizures is by EEG. The EEG will show you that there is 3 Hz, right? 3 Hz or 3 spikes, right? So there will be 3 spikes per second. Okay, so that is what is the EEG in these individuals. Then how do you treat these patients? So the treatment of the absence seizure is, if the individual is like less than 4 years, you need to give the 𝐒𝐿-succinimide, right? So you need to give 𝐒𝐿-succinimide as the drug of choice. 𝐒𝐿-succinimide as the drug of choice. But if the individual is like more than 4 years, then valproic acid is the drug of choice, okay? Because in children of age less than 4 years, right, when you give valproic acid, it is associated with severe hepatotoxicity, right? So that is the reason why you cannot give the valproic acid in children of age group less than 4 years. Okay, so that is about the story related to the absence seizures. Then coming to the myoclonic epilepsy or myoclonic jerks. So we have a terminology called juvenile myoclonic epilepsy. Right, so juvenile myoclonic epilepsy. So if you take this juvenile myoclonic epilepsy, as the word itself tells you, it is the one which begins around the age group of 15 years. And another name for this juvenile myoclonic epilepsy, this is also called as Zan's syndrome, right? So usually it starts in the adolescent age group, right? And this juvenile myoclonic epilepsy, this is characterized by a triad of the seizures. One, these patients will have a myoclonic jerks, right? And next is GTCS. Third will be the presence of the absence seizures, which are nothing but petit mal epilepsy. Okay, and what is another name for GTCS? This is called grand mal epilepsy, right? So this is nothing but your grand mal epilepsy. Okay, now if you observe among these three, which is more common type of epilepsy will be GTCS in juvenile myoclonic epilepsy. And you take this myoclonic jerks. Myoclonic jerks, they are more common, right? They are more common early in the morning after awakening, or they are more common after the alcohol intake, right? And where exactly you observe this myoclonic jerks? These myoclonic jerks, they are commonly observed over the trunk, right? And these myoclonic jerks, right, they are mainly observed over the extremities, that is the arms, right? So over the trunk and as well as the arms, the myoclonic jerks are observed. Okay, and very important is the family history. Okay, so there will be family history of the juvenile myoclonic epilepsy, right? And these patients, how will you diagnose? That is by EEG. So what does the EEG show? That is 4 to 6 hertz irregular polyspike activity, right? 4 to 6 hertz irregular polyspike activity. So that is what the EEG shows in case of the juvenile myoclonic epilepsy, right? And so what is the age group it will begin around? In the adolescent age group, that is around 20 years. Okay, and these myoclonic jerks, they are commonly observed over the trunk, extremities, and usually they observe early in the morning after awakening, or even they get precipitated by the deprivation of the sleep, right? That was about the juvenile myoclonic epilepsy. Now coming to the atonic epilepsy or atonic seizures. So atonic seizures are also a form of generalized seizures. Now in atonic seizures, there is abrupt, right? There is abrupt loss of tone in the muscles, right? So there is abrupt loss of tone in the muscles. That is what is your atonic seizures, right? And in case of atonic seizures, because of the abrupt loss of tone within the muscles, the individual will have a sudden collapse, right? Abruptly he will fall down. That is what will happen in case of the atonic seizures. And what is the drug of choice in case of the atonic seizures? The drug of choice in case of the atonic seizures are like sodium valproate. Okay, so valproic acid, that is the drug of choice in case of atonic seizures as well, right? And now in pregnancy, if you observe, what is the safest anti-epileptic drug in pregnancy? That will be levetiracetam, right? And another important molecule is next to this will be lamotrigine, right? Next to this will be lamotrigine. Okay, so this is about your generalized seizures. Now if you take the discussion related to the focal seizures, right? So in case of the focal seizures, so the focal seizures, they are also called as the partial seizures, right? Which is also called partial epilepsy. So in focal seizures, these individuals, they will have the motor activity they will have the motor activity which is originating from the precentral gyrus. Right, which is originating from the precentral gyrus, right? And this motor activity which is originating from the precentral gyrus, the involuntary movements usually affect the contralateral arm and trunk, right? It is the abnormal involuntary movements will be there in the contralateral arm and as well as trunk. And the description of the epilepsy, this is called as the Jacksonian epilepsy. Right, so this is called the Jacksonian epilepsy. So Jacksonian epilepsy is that where the involuntary movements, they begin in the tip of the fingers and then gradually they progress proximally. That is what is called the Jacksonian epilepsy, right? And one more important terminology in focal seizures that you need to know is the Todd's epilepsy. Now, what do you understand by this term Todd's epilepsy? Todd's epilepsy is that prolonged episodes of the seizures, they are associated with the development of paresis of the involved limb. Okay, so Todd's palsy is nothing but prolonged episodes are associated with the paresis of the involved limbs. That is what is called as the Todd's palsy. Okay, so it is not just only the motor involuntary movements, there will be also sensory abnormality as well. But if you take the sensory abnormality in case of the focal seizures, the activity arises in the postcentral gyrus, whereas motor activity precentral gyrus, sensory activity arises in the postcentral gyrus, right? Now, in case of the focal seizures, they also have psychomotor abnormalities. There will be alteration in the mood, alteration in the memory, alteration in the perception. Okay, so and this we call it as the temporal lobe epilepsy. What is this? So whenever there is, right, whenever there is alteration in the perception, right, or whenever there is alteration in the memory, right, so this we call it as the origin of the involuntary movement is in the temporal lobe, that we call it as the temporal lobe epilepsy. And what exactly will be the drug of choice in case of the focal epilepsy is you need to give carbamazepine. That is the drug of choice in case of the focal epilepsy. Now this is like the description of the various types of the epilepsy. Now apart from this, you need to know the anti-epileptics that are being given in various other types of epilepsy. So basically if you take in GTCS, right, in atonic and as well as in myoclonic and including the absence seizures. So in all of these, what exactly will be the drug of choice? Right, so in all of these conditions, the drug of choice will be the valproic acid, right? Then what will be the drug of choice in the febrile seizures? So the drug of choice in febrile seizures, when the individual is having an episode of the epilepsy, right? So in febrile seizures, the drug of choice will be intranasal midazolam, right? Intranasal midazolam, right? Or rectal diazepam, right? Or rectal diazepam. So that will be the drug of choice in febrile seizures during the episode. Whereas if you take the prophylaxis of the febrile seizures, right, the prophylaxis of the febrile seizures, the drug of choice will be the oral diazepam, right? Drug of choice will be oral diazepam, right? And what exactly will be the drug of choice in absence seizures in individuals of age group or children of age group less than 4 years, right? So here it will be 𝐒𝐻𝐵𝐞, right? So why don't we give valproic acid here? That is because it is associated with the hepatotoxicity where the child cannot bear that. And what exactly is the drug of choice in the infantile spasms? So in the infantile spasm, drug of choice will be ACTH, right? And what exactly is the drug of choice in infantile spasm? With tuberous sclerosis, right? With tuberous sclerosis. So here the drug of choice will be vigabatrin, right? Here the drug of choice will be vigabatrin, okay? Then the drug of choice in case of the status epilepticus, right? So in this condition, the drug of choice will be lorazepam, okay? So these are some of the important drugs that you need to give in the various types of the epilepsy, right? And in spite of giving medical management, if the individual, if suppose having medically refractory epilepsy, right, medically refractory epilepsy, then what is the alternative treatment? The diet that you need to provide is the ketotic diet. So ketotic diet will suppress the abnormal discharge from the neurons. Then another important treatment is the vagal nerve stimulation. Then next important treatment is the DBS, that is deep brain stimulation. And the next important is the best results, right? The best results are with surgery, right? The best results are with surgery. So this is about what is called as the medically refractory epilepsy. How do you treat the patient? So this finishes the quick revision of the very important topic, that is epilepsy. So the next important topic for the quick revision is the meningitis. So meningitis, like how do we define it as? So it is the clinical scenario where there is acute purulent infection in the subarachnoid space. So in the subarachnoid space, right, so there is accumulation of the purulent fluid, and this accumulation of the purulent fluid, either it could be because of the bacterial infection, or it could be because of the viral infection or tuberculosis or the fungal infection, right? And along with meninges, if there is also involvement of the enkephalon, that is brain parenchyma, then we call it as meningoencephalitis. And in case of meningoencephalitis, the clinical features that these individuals will have is, in meningitis, the important manifestation is headache, right? And whereas in meningoencephalitis, along with headache, these patients will also develop seizures, right? These individuals, right? So they will also have the seizures. And along with seizures, these patients will also have the altered sensorium, or they may even go into a state of the loss of consciousness, right? This is in case of meningoencephalitis. Now, if you take the organisms that are causing meningitis, what is the most common bacteria that will be causing meningitis? That includes the Streptococcus pneumonia. So Streptococcus pneumonia, it is also the organism which will be causing, which is the most common organism that is causing community acquired pneumonia. And apart from this, like we have the Neisseria meningitidis, then we have the Haemophilus influenza, then we have group B Streptococcus. So these are all the various organisms or bacteria that will be causing the meningitis. And what is that particular organism which is associated with post-meningitis deafness? Okay, so post-meningitis deafness, it is observed in case of Haemophilus influenza, right? So post-meningitis deafness, right? So it is observed with the Haemophilus influenza. And according to the age group, if you observe in the neonates, what is the most common organism that will be causing meningitis? In neonates, particularly in India, the most common organism will be the Klebsiella, right? And then followed by that, the Escherichia coli, right? Whereas you take in case of children and as well as in adults. In children and adults, in both of these group of individuals, the most common organism that will be causing meningitis will be pneumococcus, right? That includes pneumococcus in children and as well as the adults, right? And you take this gram-negative bacilli. Gram-negative bacilli that will be causing meningitis, they are very commonly observed in diabetic patients, patients with cirrhosis of liver, patients with alcoholism. Okay, so gram-negative bacilli causing meningitis is observed in chronic and debilitating diseases such as diabetics, cirrhosis and alcoholism. Now, what will be that gram-negative bacilli? So the gram-negative bacilli that will be causing meningitis, that includes the Escherichia coli, that includes the Salmonella, and that includes the Shigella. Okay, so Escherichia coli, Salmonella and Shigella. So these are the gram-negative bacilli that will be causing meningitis, right? And very important is this Neisseria meningitidis, that is meningococci. Neisseria meningitidis like causing meningitis. What is the spread of infection of this Neisseria meningitidis infection? That is by, right? So that is by the droplet infection, right? Then what will be the clinical features that are observed in case of the meningitis? So in meningitis, you have a very important triad. What is a very important triad in meningitis? The very important triad in meningitis that includes headache. Along with headache, these individuals, they will have a very high grade fever, right? And along with headache and high grade fever, whenever you examine these patients, they will have neck rigidity or, right, or they will be having nuchal rigidity, right? And whenever they are exposed to the sun, right, so they will be having photophobia. They will be having photophobia. And in patients with meningitis, the intracranial pressure is raised, and because of which you will notice that there is presence of the papilledema. So these are the triad in case, so the triad basically include these three, that is headache, fever and as well as nuchal rigidity. And apart from that, the other manifestations like photophobia, and on examination there can be also papilledema. And on examination there are important signs that will be positive. That includes number one, the 値 sign, right? So the 値 sign will be positive, which is nothing but the individual when he lies down in supine position and you, right? So what should be the position of the individual? So in supine position, the individual, like he should flex the hip and flex the knee. And with that flexed knee you try to straighten, he will not be able to do that. There will be severe pain. So 値 sign will be positive. Then Brudzinski's neck sign, right? So Brudzinski's neck sign, that will be positive. That will be the on examination. And how do you work up these patients? What will be the investigation of choice? That is by the CSF analysis, right? That is by the CSF analysis. Okay, so you need to do the lumbar puncture. And what is the name of the needle when you are doing the lumbar puncture? Is the needle is the Quincke's needle, right? Or this is also called as the Sprott's needle, right? The Quincke's needle or the Sprott's needle. Okay, so then when you are doing the culture, whenever you are taking the sequence, like what is the sequence that you need to follow? First, you need to draw the blood culture. Right, first you need to draw the blood culture. Followed by that, you give an empirical antibiotic, right? Then followed by that, you do neuroimaging to look for the presence of any space occupying lesion, and then finally you do lumbar puncture. And if the neuroimaging shows that there is severely raised intracranial pressure, you cannot do the lumbar puncture. That's very, very important point. Okay, so if the neuroimaging shows that the raised intracranial pressure is not very severe, then you can go ahead with the lumbar puncture. And whenever you are doing this lumbar puncture, what should be the site of the lumbar puncture? That should be between L3 and as well as the L4, right, with the help of the Quincke's needle or the Sprott's needle. Then what are the contraindications for doing the lumbar puncture is, the contraindications for the lumbar puncture include, number one, the bleeding tendencies. Okay, so bleeding manifestations, they are the contraindication for lumbar puncture, right? Next, if there is any presence of the local site infection, that is a contraindication for lumbar puncture. And if there is any spine abnormality, right, so this is also the contraindication for the lumbar puncture, right? Then for, and even the polio, this is also the contraindication for the lumbar puncture. And whenever you do lumbar puncture and whenever you are trying to remove the CSF, how much of the CSF that has to be removed, the quantity of the CSF that has to be removed, it is around 20 to 30 ml, right? And why is it you are removing 20 to 30 ml is because if you see the rate of production of the CSF, the rate of production of the CSF, it is around 20 ml per hour within the choroid plexus of the ventricles. And what is the total amount of the CSF, right? What is the total amount of the CSF which are present within the ventricles and in the subarachnoid space is around 150 ml, around 150 ml. And what is the very important adverse effect associated with the lumbar puncture is the development of the headache. That is the, so then how is that you will be able to treat this post lumbar puncture headache, right? You need to advise the bed rest. You need to advise the bed rest, right? Or you can give the IV caffeine, which is the drug of choice. Okay. Now, what should be the position of the individual whenever lumbar puncture is being done is the individual should be lie down in the lateral position, either right lateral or left lateral, and the knees have to be completely bent and the hips also have to be completely flexed, and even the neck also has to be completely flexed. And if the individual is not able to lie down in the lateral position, then he has to sit and bend forward so that the intervertebral space is like enlarged. Okay, so that is about the how you will do the lumbar puncture. Then followed by that, you need to be completely aware of, right, you need to be completely aware of the CSF analysis. So when you do this, when you see the CSF analysis, what are all the things that you need to check for in the CSF analysis? One is the pressure, right? The CSF pressure, color of the CSF, cells, sugar, and proteins. If you take the normal CSF pressure, that is around 50 to 180 millimeters of water, right? 50 to 80 millimeters of water. And the color of the CSF, it is like clear, like water. And the number of cells within the CSF is 0 to 4 cells or 0 to 4 lymphocytes per cubic millimeter. And if you take the quantity of the sugar, that is around 2/3 of the blood sugar, right? 2/3 of the blood glucose. And the protein content, if you observe, it is around 15 to 45 milligrams percentage. This will be the protein content. This is normal, right? Whatever we have discussed is like normal. Then you take in case of the bacterial meningitis, the CSF pressure is increased and the CSF will be turbid because of the presence of the inflammatory cells, and the cellular component is increased, that is mainly the neutrophilic predominant, right? And the glucose is completely utilized, so the CSF sugar is reduced, and the protein component is also increased because the antibodies are being produced against the bacteria. And what are these antibodies? These antibodies are nothing but the proteins. Okay, so the antibodies, they are being elevated. So this will be the picture in case of the bacterial meningitis. Then you take in case of the tubercular meningitis. Also, the CSF pressure is increased. The color of the CSF, it will be like straw colored fluid. the cellular component is increased, that is mainly the lymphocytic predominant, right? The number of cells will be like more than 100 cells per cubic millimeter. The glucose or sugar will be reduced and the protein is increased. That is observed in case of tubercular meningitis. Then you take in case of the viral meningitis. In viral meningitis also, the CSF pressure is increased. The color of the CSF, it is like clear. And cellular component, if you observe, it is lymphocytic predominant. But the number of cells that will be elevated is more than 25 cells per cubic millimeter. And the glucose levels will be normal, but the protein content will be increased. Okay. And the viruses, that is mainly the ecovirus or the herpes simplex virus, they are the one which are associated with the meningitis or meningoencephalitis. Then followed by that, you take the fungal meningitis. In fungal meningitis also, the CSF pressure is elevated, right? The color of the CSF is like clear, and it is mainly lymphocytic predominant, and the number of lymphocytes that will be elevated is around 25 to 100 lymphocytes per cubic millimeter. The glucose is utilized and the protein content will be increased. So this will be the CSF analysis in case of all the forms of meningitis. Then particularly you take in case of the tubercular meningitis. In case of tubercular meningitis, what is the mode of spread? Actually, it is from the lung, it is being spread to the brain. The mode of spread from the lung to the brain, it is by the hematogenous spread, right? It is by hematogenous spread. And these patients with tubercular meningitis, right? So they are associated with the development of the basal meningitis. So that is the reason why whenever you are treating this tubercular meningitis, so directly we don't give the anti-tubercular drugs. We give steroids first and then followed by that we give anti-tubercular drugs. Okay. And in case of the tubercular meningitis, when it is usually observed in children, right? So you have this, that is mainly in the newborn, right? So you have what is called a crackpot sign. And when you take the CSF and you place it in the test tube, right? What is that you will place in the, what is that you will observe within the test tube of these tubercular meningitis CSF is, you will have the presence of what is called cobweb coagulum. Right, so you have the presence of what is called cobweb coagulum. So cobweb coagulum is that where you have the presence of proteins within the cobweb. So these proteins, they get condensed within the test tube, right? That is in case of the tubercular meningitis, right? So when you do imaging, when you do CT or MRI in case of the tubercular meningitis, that will show you the presence of the hydrocephalus. Right, so that will show you the presence of the hydrocephalus. Okay, and when you do the cross section of the brain parenchyma in tubercular meningitis, the tubercular organism from the meninges, it can spread to the brain parenchyma. So whenever you take the section of the brain parenchyma after the death of the individual, you will observe a focus which is called as the rich focus. Right, what exactly is this particular rich focus? That is nothing but tubercular granuloma observed in case of patients with the tubercular meningitis. Okay, so why is it called rich focus? Is because it is first discovered by a pathologist, that is Arnold Rice Rich in Johns Hopkins Hospital. That is the reason why it is called the rich focus. And the complications that are associated with the tubercular meningitis, that is mainly the hydrocephalus, right? Then I said you the crackpot sign. The crackpot sign, this is also called as Massivan sign. Right, this is also called Massivan sign. So Massivan sign, which is also known as crackpot sign. So this Massivan sign or crackpot sign, it is elicited by percussion of the skull. It is elicited by the percussion of the skull. Okay, so basically this Massivan sign or crackpot sign, it is an amplified sound that can be heard from the stethoscope from the other end. Okay, so if this Massivan sign is positive or crackpot sign is positive, what does it indicate? It indicates, or it is indicative of the separated sutures. Right, so this is indicative of the separated sutures. So this tells that there is raised intracranial tension. This tells that there is raised intracranial tension. Then what exactly is the investigation of choice in case of the tubercular meningitis is, you need to do a TB PCR. on, right, you need to do TB PCR analysis on the CSF, okay, which is nothing but your CBNAT. So CBNAT, it stands for the cartridge based nucleic acid amplification test, or which we also call this as gene expert. Then what is the treatment that you will give in these patients with the tubercular meningitis is you need to give anti-tubercular drugs, and this anti-tubercular drugs you need to give for nearly around 6 to 8 months. Okay, so this is about the tubercular meningitis. So what did I tell you before starting anti-tubercular drugs? You need to give a short course of steroids, and this particular short course of steroids will reduce the cerebral edema. And not only that, by giving the short course of steroids, the inflammation will get reduced, and the anti-tubercular drugs, they can penetrate into the CSF very easily. So that is the importance of the anti-tubercular therapy, right? Now, then followed by that, you take the quick discussion on the viral meningitis. So viral meningitis, what exactly is the drug that will be organism causing viral meningitis is, the most common virus will be enterovirus, right? The most common virus will be enterovirus. Then what is the most common cause of viral encephalitis? The most common cause of the viral encephalitis, it includes Japanese bee encephalitis. Right, so that includes Japanese bee encephalitis, that is in India, right? Whereas globally, the most common virus that will be causing the viral encephalitis will be herpes simplex virus 1, right? That is HSV1. And this HSV1, it has the predilection to the temporal lobe, right? It has the predilection to the temporal lobe, and thereby these patients can develop dementia, right? Thereby these patients can develop dementia, right? And when you do the CSF analysis in case of this viral encephalitis, you can have the presence of lymphocytes. There will be lymphocytic predominant. Then what exactly is the investigation of choice? You need to do PCR for the HSV1 on the CSF. And when you do a EEG in case of the HSV1, EEG will show you the presence of what is called as the PLED. What do you mean by this word PLED? Periodic lateralized epileptiform discharge. That is what is called PLED. Okay. Whereas you have another EEG abnormality, that is periodic sharp wave complexes. Periodic sharp wave complexes, they are observed in prion disease, that is Creutzfeldt-Jakob disease. But whereas periodic lateralized epileptiform discharge is observed in the HSV1. What exactly is the drug of choice? Drug of choice will be, you need to give empirical acyclovir, right? Empirical acyclovir, right? Then followed by that, the next important is the fungal meningitis. The common organism that will be causing fungal meningitis, that will be Cryptococcus meningitis. But this Cryptococcus meningitis causing meningitis, this is very commonly observed in immunocompromised individuals like HIV or diabetics, or those individuals who are on the steroid therapy, or those individuals who are on the immunosuppressive therapy. And what is the portal of entry of this cryptococcal meningitis is from the lungs, it goes to the brain. And in the treatment, what is that you give in cryptococcal meningitis is liposomal amphotericin B, right? And 5-fluorocytosine, 5-fluorocytosine, okay? And at the time of discharge, like we give the fluconazole, right? We give fluconazole. So that will be for the fungal meningitis, right? So this is about your and in case of bacterial meningitis, what is the treatment? In bacterial meningitis, the empirical treatment that you need to start is ceftriaxone, and the dosage of the ceftriaxone in bacterial meningitis, it should not be like 1 gram, it should be 2 grams IV, and along with that you need to give vancomycin. Okay, so ceftriaxone and the vancomycin. These are the empirical drugs that we give in case of bacterial meningitis. Then followed by that, the next important treatment will be depending upon the culture and sensitivity of the CSF analysis, right? So this is, and you need to be very much aware of the complications. As I have already said you, the complications that you are observing in case of the meningitis will be mainly the hydrocephalus. Why there is hydrocephalus is because the CSF will not be absorbed at the level of the subarachnoid space because of the granulations or because of the inflammation, right? And the other important complications will be electrolyte abnormality, and this electrolyte abnormality will be in the form of the hyponatremia, and that is usually due to development of the SADH, syndrome of inappropriate antidiuretic hormone. And not only that, some patients with chronic meningitis, they also develop diabetes insipidus, and that too central diabetes insipidus. And because of raised intracranial pressure, right, you know, there will be a cranial nerve palsy, right? Cranial nerve palsy, mainly those cranial nerves which are having long intracranial course, that is 4th cranial nerve or 6th cranial nerve, they get compressed. Okay, and the next important complication will be there can be even development of the stroke as well. And some patients, they not only develop meningitis, they also develop what is called meningoencephalitis. Right? They also develop what is called meningoencephalitis. And whenever they develop meningoencephalitis, they have this psychotic behavior or altered sensorium will be there. Okay. And the next important is in tuberculosis, there can be development of the complication that is tuberculoma. That is tuberculoma. Okay, and in some patients there will be also development of what is called hypothalamic syndrome. Okay, so these are the complications which are associated with the development of meningitis, right? And we have some drugs that will be causing meningitis. Okay, so drugs causing meningitis. Drugs causing meningitis that include mainly they are like drug hypersensitivity reaction. So drug hypersensitivity, it is incriminated in causing chronic meningitis. And in case of drug hypersensitivity reaction, whenever you do a CSF analysis, that will show you the presence of the eosinophils. And these eosinophils, they are elevated within the CSF. And what are the drugs that will be causing the meningitis? That is the NSAIDs. Next includes sulfonamides, right? Then followed by that isoniazid, then ciprofloxacin, right? The next important drug will be penicillin, and next is lamotrigine. Right, lamotrigine. Okay, so these are all the drugs that will be causing meningitis. And we have one more terminology called molarate meningitis. So molarate meningitis is nothing but recurrent meningitis. Okay, and basically it is an aseptic meningitis. Aseptic meningitis is nothing but your molarate meningitis. Okay, so this is about the quick recap related to the topic of the meningitis. So the next important topic for the quick revision is the cerebrovascular accidents. So you need to know the very important definition of a terminology, that is stroke. Stroke, it is defined as the sudden onset, the neurological deficit. And this sudden onset neurological deficit, it should be mainly of the vascular basis. Right? This should be of mainly the vascular basis, and the neurological deficit, it should last longer than 24 hours. Right? It should last longer than 24 hours. Okay. And the another terminology is the TIA, that is transient ischemic attack. So it is transient ischemic attack where there is sudden onset neurological deficit, right? Where there is sudden onset neurological deficit, and that also should be of vascular basis, and this neurological deficit, it should resolve, right? The neurological deficit should resolve within 24 hours. Right? It should resolve within 24 hours. This is what is called the neurological deficit. And another terminology, that is RIND. The word RIND is reversible ischemic neurological deficit. Reversible ischemic neurological deficit is that where the neurological deficit that will be present for more than 24 hours, right, for more than 24 hours, and it resolves, right, it resolves within 72 hours. Okay, the neurological deficit that will be there for more than 24 hours and resolve within 72 hours. So this is what is called as the RIND, reversible ischemic neurological deficit. Now, a patient with repeated episodes of the TIA, right, a patient with the repeated episodes of the TIA, they go into a stage of stroke, right, they go into a state of stroke. Now, what is that parameters which will decide that the patient will go into a state of stroke? So we have a scoring system called ABCD2 scoring system, right, ABCD2 scoring system, right, where A is representing the age of the individual. If it is more than or equal to 60 years, then give a score of 1, right. B stands for the blood pressure, where the systolic blood pressure of the individual being more than 140 and the diastolic blood pressure of the individual more than 90, give a score of 1. Then C stands for the clinical feature. What will be that? That is unilateral weakness, or if there is any presence of the speech disturbance. So if the patient is having unilateral weakness, give a score of 2, right? And if the patient is having any disturbance within the speech, give a score of 1. And D stands for the duration. Okay, if suppose if the TIA duration, the duration of the TIA, if it is more than 60 minutes, right, then give a score of 2. And if the score of TIA is in between 10 to 59 minutes, right, then you need to give a score of 1. And the another D is diabetes mellitus. So if the individual is diabetic, then give a score of 1, right. So if you take the total score, it will be around 7, because the age is coming for almost 2 times. So age more than 60 years, right, and yeah, so the age is like only 1 time. But if you take the clinical feature, any of these you should take, right, and even the duration, right, it is coming for the 2 times. If the more than 60 minutes 2 and 10 to 59, it is 1. So the total score is 7. So more is the score of the ABCD, right, then more is the chance that a patient with TIA will go into a state of stroke, right. So more is the chance that a patient with the TIA will go into a state of stroke. Now, if you take the etiology of the stroke, so if you see this etiology of the stroke, we classify the etiology of the stroke into 2. One is an ischemic stroke. Second one is hemorrhagic stroke, right? Ischemic stroke and hemorrhagic stroke. Ischemic stroke is more common than compared to that of the hemorrhagic stroke. Ischemic stroke, they contribute around 85%, and hemorrhagic stroke, they contribute around 15%. And if you take this ischemic stroke, the ischemia, it is mainly because of thrombosis, right, or it could be because of the embolism, right. So this could be because of the embolism. So out of which embolism, it contributes 75%, and thrombosis, this will contribute 25%. And whereas you take the hemorrhagic stroke, the hemorrhagic stroke, we have the intraparenchymal type of the hemorrhage causing intraparenchymal cause for the hemorrhage causing stroke. Second one is subarachnoid hemorrhage, right? Third is subdural hemorrhage. Fourth is the extradural hemorrhage. So these are the causes for the hemorrhagic stroke, right? Now out of all these, the most common type of, right, out of all these, the most common type of the hemorrhagic stroke will be intraparenchymal stroke, right? So the most common cause will be the intraparenchymal stroke, right? Which one among the hemorrhagic stroke, right? Among the hemorrhagic stroke, the most common will be the intraparenchymal stroke. And overall, what is the most common cause of the stroke? Overall, the most common cause of the stroke will be the embolism, right? That will be embolism, okay? Right. Now, if you take this embolism, the most common source for the embolism will be the heart, right? The most common source of the embolism will be the heart, that is intracardiac thrombi. Okay, so the intracardiac thrombi is the source of the embolism. Now, what is the reason for the development of the intracardiac thrombi? That is the ST elevation MI causing the severe left ventricular failure, right? And the next one is the atrial fibrillation. These will be the causes for the thrombus, and which will shower an embolism into the cerebral circulation, causing the cerebrovascular accident. So if the question is asked like what is the most common cause of the intracranial hemorrhage, right, that is hemorrhagic stroke, that includes the intracerebral hemorrhage, right? That includes the intracerebral hemorrhage. Okay, then what is the most common cause of the intracerebral hemorrhage? That will be the hypertension, right? Then what are the other causes for the intracerebral hemorrhage? The other causes for intracerebral hemorrhage include rupture of the saccular aneurysm causing subarachnoid hemorrhage. There can be rupture of AV malformation, right? The cavernous angioma rupture can occur, and even the trauma, right? Whereas the most common cause of intracerebral hemorrhage will be the hypertension. Then what will be the most common site of the hypertensive hemorrhage? The most common site of the hypertensive hemorrhage will be, right, so will be within the putamen, right, will be within the putamen, which is nothing but the part of the basal ganglia. Then followed by that, the other sites will be the deep cerebellum, right, and also in the pons, right, also in the pons. So this will be the sites of the intracerebral hemorrhage, right? Then coming to the subarachnoid, so the most common cause of the intracerebral hemorrhage was what? That is hypertension. Okay, then coming to the subarachnoid hemorrhage. If you take subarachnoid hemorrhage, the most common cause of the subarachnoid hemorrhage will be the head trauma, right, will be the head trauma, and followed by that the rupture of the berry aneurysms. Right, followed by that the rupture of the berry aneurysms. Okay, now if you take these berry aneurysms are the aneurysms which are originating from the circle of Willis, right? These are the aneurysms which are originating from the circle of Willis. Then what is the most common site of the berry aneurysm? The most common site of berry aneurysm will be at the junction of the anterior cerebral artery with the anterior communicating artery. Right, anterior cerebral artery with anterior communicating artery. That will be the most common site of the berry aneurysm, right? And if this berry aneurysms rupture, these individuals will develop what is called the subarachnoid hemorrhage, right? And whenever there is subarachnoid hemorrhage, what will be the clinical feature is the severe form of headache. Okay, so the patient will be complaining of a thunderclap headache, right, or the worst headache of the life. That will be the headache in case of the subarachnoid hemorrhage. Okay, and The next important point in case of the subarachnoid hemorrhage is, on examination, you will have the presence of the neck rigidity. Right, so you will have the presence of the neck rigidity or neck stiffness. And what exactly will be the investigation of choice in case of subarachnoid hemorrhage? The investigation of choice in case of subarachnoid hemorrhage will be non-contrast CT scan. And when you do a non-contrast CT scan, that will show you the presence of blood in the sylvian fissure. Right, that will show you the presence of blood within the sylvian fissure. Okay, and when you do a lumbar puncture also, you will have what is called 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞. Right, 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞, right? And what will be the treatment that you will be giving is, now it is like completely, if suppose when you do an imaging and if there is no midline shift, right, so if there is no midline shift, then the treatment is the conservative treatment or conservative management, or the supportive treatment if there is no midline shift. And if suppose there is presence of the midline shift, then in such case you need to do the craniotomy, or the exploratory craniotomy has to be done in order to relieve the intracranial pressure if there is presence of the midline shift. Okay, and the next is, you need to give analgesics, that is mainly for the headache, right, like naproxen, right? And the next important point here is, you need to give the calcium channel blockers, right? That is nifedipine or nimodipine should be given. Why? Because these patients with subarachnoid hemorrhage, they will have compensatory cerebral vasospasm to prevent the bleed from the circle of Willis. So whenever there is compensatory vasospasm, the individual can develop infarct. So in order to prevent that, you need to give the calcium channel blockers. That is about the subarachnoid hemorrhage, right? Now, coming to this, so the most common cause of stroke is what? Is it ischemia or is it like the hemorrhage? It is ischemia, right? Now, the very important question is, cerebral ischemia occurs, right? The very important question is, the cerebral ischemia occurs when the cerebral blood flow, if it is less than 20 ml per 100 gram per minute, then there will be development of the cerebral ischemia. So cerebral blood flow should be how much? Less than 20 ml per 100 gram per minute. Now, how is that you will be able to differentiate the hemorrhagic stroke from thrombotic and as well as the embolic stroke? Okay, so you take the time of onset. In case of the hemorrhagic stroke, usually during the activity, right, usually during the activity or heightened excitation or emotion, there can be like rise in the blood pressure and burst of the blood vessels causing hemorrhagic stroke, right, or even trauma. So time of onset is mainly during the activity, whereas thrombotic stroke, if you observe, the time of onset is during sleep. Embolic stroke, right, anytime. Embolic stroke, anytime. Okay, and how will be the progression? You take in case of hemorrhagic stroke, the progression will be over minutes and even it can take hours. Whereas thrombotic stroke, if you observe, on waking up, the patient will notice that there is neurological deficit. And embolic stroke, the progression will be within seconds. Right? Progression will be within seconds. And what about the presence of transient ischemic attacks? In hemorrhagic stroke, the transient ischemic attacks, they are absent. Whereas the transient ischemic attacks, they are present in the ischemic strokes, that is in thrombotic and as well as the embolic stroke. And what about the presence of the vomiting? Right? What about the presence of the vomiting? Vomiting in case of the hemorrhagic stroke, these patients, they'll have a recurrent vomiting, right? Whereas in ischemic stroke, usually the vomiting is absent or occasionally it may be present. And what about the headache? Headache, it is very prominent in case of the embolic stroke, whereas in thrombotic and as well as the hemorrhagic stroke, the headache is very prominent, whereas it is mild or absent in both of these ischemic stroke. Right, that is both the thrombotic and as well as the embolic stroke, right? And which is the type of stroke where there will be early resolution? So the type of stroke where there will be early resolution is in embolic stroke. So embolic stroke, there is possibility of the early resolution, whereas in hemorrhagic stroke it is unusual, whereas in thrombotic stroke it is variable. That is about the early resolution. Next is, what about the presence of meningeal irritation? Right, what about the presence of meningeal irritation? Meningeal irritation, it may be present in hemorrhagic stroke but absent in both of these ischemic stroke, that is thrombotic and embolic stroke. And what about the presence of the carotid bruit? Carotid bruit, it is usually absent in case of the hemorrhagic stroke, but there is high chances that it can be present in the thrombotic stroke and as well as the embolic stroke, that is carotid bruit. And what about the presence of the valvular heart diseases? Valvular heart diseases, they are very commonly observed in the embolic stroke rather than the thrombotic or the hemorrhagic stroke. Okay, valvular heart diseases, right? Then CT, if you observe, in hemorrhagic stroke, you have the presence of the hyperdense lesions, right? This hyperdense lesion, that is suggestive of the hemorrhage, whereas in ischemic stroke, you will have a pale infarct and that we describe it as the hypodense lesion, right? We describe it as the hypodense lesion in both the thrombotic stroke and as well as the embolic stroke. Okay, and if the site of ischemia, if the thrombosis and embolism, if the site of the ischemia is like large enough, right, if the site of the ischemia, if it is large enough, this can undergo hemorrhagic conversion. Right, this can undergo hemorrhagic conversion. Okay, next, if you take the treatment in case of the hemorrhagic stroke is again just now as I was discussing, if there is no midline shift, then it is just only the conservative treatment or supportive management. If there is presence of a midline shift, right, then you need to do the exploratory craniotomy to relieve the intracranial pressure. Whereas in thrombotic and embolic stroke, that is ischemic stroke, if the individual presents within 4.5 hours of the onset of the clinical features, right, both in thrombotic and embolic, if they present within 4.5 hours of the onset of the clinical features, then you can do a thrombolytic therapy with tissue plasminogen activator. Okay, within 4.5 hours. But if the patient comes after 4.5 hours, thrombolytic therapy, it is avoided or it is contraindicated or it will be of no use. Then in such case, you need to just give the anticoagulant, that is aspirin, and then anticoagulants, that is the low molecular weight heparin, can be given. And along with this, the physiotherapy is required in the individual in order to ensure that the neurological deficit will recover back immediately. Okay, so that is about the treatment in case of the hemorrhagic, thrombotic and as well as the embolic stroke. And one more important part of the discussion in the cerebrovascular accidents is like what will be the functioning of the left cerebral hemisphere and functioning of the right cerebral hemisphere. Left cerebral hemisphere, this is considered as dominant hemisphere, or we call this as the categorical hemisphere. Whereas right hemisphere, this is considered as representative hemisphere. Right, this is considered as representative hemisphere. Now, if you take the categorical hemisphere, that is left hemisphere. These patients, the left hemisphere functioning is, number one, right-handed control, right? The control of the spoken language, control of the written language, right? Control of mathematical skills, control of scientific skills, and then reasoning. Okay, so this will be the functioning of the left hemisphere, which is also called categorical hemisphere. Now, whenever there is lesion, right, whenever there is damage to the left cerebral hemisphere, then what will be the clinical features? One of the very important clinical feature is the development of the aphasia and even dyscalculia. Okay, because this complex mathematical skill is controlled by the categorical hemisphere, and if that is being damaged, the patient will develop what is called dyscalculia. Then what will be the functioning of the right cerebral hemisphere? Functioning of the right cerebral hemisphere is visuospatial orientation of the individual. Number two, control of left hand control. Then next is music awareness, right? Then followed by that, three-dimensional awareness, awareness of the art, then insight, and as well as the imagination. Right, insight and imagination. So that will be like functioning of the right hemisphere. Then what will be the clinical features if there is damage to the right cerebral hemisphere? These individuals, they will have astereognosis. What is this astereognosis? Where the individual has inability to recognize the objects by feeling them. That is called astereognosis. Then followed by that, the other important feature of right cerebral hemisphere damage is the agnosia, where there is inability to process the sensory information. And in agnosias, the individual has loss of ability to recognize the objects. The individual has loss of ability to recognize the person. The individual has loss of ability to recognize the sound, shape, and even smell. That is called agnosia, right? And next is anosognosias. Anosognosia is called as lack of insight, right? It's a lack of insight. So it's a symptom of severe mental illness experienced by some that impairs a person's ability to understand. Okay, so the individual cannot understand or cannot perceive that he or him, like, or his or her illness. That is what is called anosognosia. And the next important is dysgraphia. Right, so dysgraphia or agraphia. What is this dysgraphia or agraphia? That is inability to write coherently. Inability to write coherently is what is called as the dysgraphia. Okay, so this dysgraphia, it is one of the symptom of the brain disease or the brain damage. Okay, so this is about the quick revision of the cerebrovascular accidents. So this finishes the total revision of the entire neurology. Thank you very much.